Samarjit sir, very good evening.
Good evening,
Hello.
sir.
Good evening, everybody. Good evening,
Avinash sir.
President sir.
Avinash sir,
Good evening.
Good
काय
evening,
म्हणता?
राजेश. काही नाही चालू
good
आहे.
evening sir. Good evening sir.
Preparing
Good
for
evening,
battle.
दिलीप, अनिता,
Hi, Avinash.
पर्णा.
Preparing.
Preparing for battle.
Yes.
You have finished.
Yes, thankful.
It's now
Vanita
my
madam,
my turn.
Yes, yes.
Uh,
Yes.
it is very difficult.
Yes.
Yes, we know how difficult it was.
Yes.
Tension is rising now
Yes.
since today only.
Yes. पण त्याचं महत्व जास्त असतं सर असं मिळालं की.
महत्व असं काही नाही आहे तसं. तसं काय असं वाटत नाही मला. महत्व त्यामुळं काय वाढतं ठीक आहे, पण इतका त्रास घेऊन कधी कधी वाटतं की आपण करायचं का.
नाही बरोबर, खूपदा वाटतं तसं.
हा म्हणजे आपण एवढ्या आता ऑलरेडी 2-3 वर्ष काम केलंय,
हो ना.
तरी सुद्धा आपल्याला फाईट करायला लागणार असं दिसतंय.
हो.
हम्म.
गुड इव्हनिंग सिद्धार्थ वर्मा सर.
Good evening, sir.
Good evening sir.
गुड इव्हनिंग सर.
Good evening. How are you, sir?
फाईन. माया मॅडम काय म्हणताय?
Hello, Maya.
Hello, good evening. Good evening.
Good evening,
How are you
Maya.
all?
Good evening Maya madam.
Good
विकास,
evening.
Good evening.
Good evening. Good evening, everyone.
गुड इव्हनिंग
कातकडे
विकास,
सर.
दिलीप.
Katkade sir,
कातकडे सर,
नमस्कार.
गुड इव्हनिंग सर.
Good evening to all. Good evening, sir.
Katkade sir, good evening.
Good evening, sir. Good evening to all.
खूप दिवसांनी सगळ्यांच्या भेटी होत आहेत असं वाटतंय मला, कारण मी मध्ये आली नव्हती ना. तर मला खूप जणांचं
आम्ही
मी
तेव्हा
कराडला नव्हते
भेटतो.
आले ना, त्याच्यामुळे मला असं आधी सगळेजण खूप भेटल्याचा वेगळंच आनंद होतोय.
गुड इव्हनिंग उमेश.
Hi, Umesh. Yes.
Hi, ma'am. Hi, sir.
हाऊ आर यू.
Fine, sir. All the best.
हो, यश यश. अविनाशला ऑल द बेस्ट.
थँक्यू एव्हरीबडी.
राजेश एक मिनिटांनी चालू करूयात.
गुड इव्हनिंग बालाजी सर,
हा
नेते मॅडम, अविनाश सर, राजेश सर.
गुड इव्हनिंग. गुड इव्हनिंग.
दिलीप.
Hi, Dilip.
Good evening.
हॅलो मॅम.
Hi, Samir.
समीर जॉईन झालाय.
समीर
Join झालाय हो.
नमस्कार.
नमस्कार.
नमस्कार नमस्कार.
गाववाले नमस्कार.
राम राम. नमस्कार सर. हाय हाय
हो, हे बरोबर आहे, गाववाले.
गावाले ऑनलाईन भेटतायत.
हो.
बिझी आहेत सगळे.
बरोबर आहे बाबा.
आज सीझर मध्ये नाही येत.
हा.
नाही
Avinash sir is not in section, so that's a surprise. Otherwise, he's always in a section.
नाही, ऑलरेडी 2-3 कार्यक्रम अजून आहेत. आता एक IMA च एक वुमन्स IMA कोरेगावचं एक इन्स्टॉलेशन.
वुमेन विंगचा.
हा, वुमन म्हणजे वुमन टीमचा नाहीये, वुमन टीम आहे पूर्ण आता. प्रेसिडेंट, सेक्रेटरी आणि ट्रेझरर. त्यामुळे हा
आमच्यासारखंच.
हो, त्यामुळे इन्स्टॉलेशन आहे त्यांचं तिकडे. एका कार्यक्रमाला जायचंय.
ओके,
2 कार्यक्रम आहेत.
अविनाश, वेगळी विमेन्स विंग नाहीये, मग मेन्स विंग ठेवा.
ते आवश्यक आहे आता.
आता ते आवश्यक आहे म्हणतायत.
हॅलो, एक मिनिट सर. मला वाटतं आता आपण चालू करूया. काही हरकत
हा.
नाही. Yes.
Ganesh, please
Good
mute
evening
everyone.
all. Yes. Good evening all respected IS members, SAMS members. First of all, I would like to welcome Dr. Samarjit Dey sir from Mangalagiri in Andhra Pradesh and Dr. Umesh Ramtani, who both are the speakers for today's webinar. And today's moderator, Dr. Siddharth Verma sir from Navi Mumbai. Today is the sixth webinar by SAMS on the recent advance with the theme recent advances in anesthesiology. And today's topic is recent advances in chronic pain management and acute pain management. I would like to request Dr. Balaji Asegaonkar, our president, sir, to brief about this SAMS webinar series.
Good evening all. I personally welcome all of you for this recent advances series of Society of Anesthesiologists Maharashtra State. Till date, we have many topics covered in this recent advances series, and all of you have appreciated that. Thank you for that. And today also we are discussing about recent advances in chronic pain as well as acute pain management. We have a very good faculty as well as very experienced moderator, Dr. Verma sir. And as you know, we have a very established system for, I think, chronic pain management, but unfortunately, acute pain management services are not that much active, particularly in corporate hospital, or very few corporate hospital have acute pain services. I hope today's lecture will inspire us to start acute pain services. And today we are fortunate that we have Umesh Ramtani to talk on acute pain and Dr. Samarjit Dey for chronic pain recent advances. I wish this recent advances series best wishes, and I request Dr. Rajesh to continue the meeting.
Today, I'm very happy to say that we are releasing second issue of SAMS newsletter. First, we will release the SAMS newsletter second issue, and then we will proceed for today's webinar. I would like to request Dr. Balaji Asegaonkar sir to release second issue of SAMS newsletter. Dr. Balaji.
Yes, thank you very much, Rajesh. I congratulate Dr. Parna for this SAMS newsletter, and I appreciate the efforts of all editorial board, Dr. Rajesh, Dr. Parna, and I congratulate Parna for that. Thank you very much.
Thank you very much, sir.
I would like to request Dr. Parna ma'am to say a few words about this second issue.
Yeah.
Parna ma'am.
Yes, yes. So, good evening all. Respected Balaji sir, Tagadpalle sir, Anita madam, Avinash Bhosle sir, Vikas Karne, and all the executive committee members of SAMS. Thank you for this opportunity. It indeed is a very proud moment for me on the occasion of release of second newsletter of SAMS. I always had a dream that SAMS newsletter should cover all the branches of Maharashtra state. So we had decided to go alphabetically in that order and include all the branches of Maharashtra state. I did have some difficulty while collecting the articles from, and contacting people. But when I called them, I just said that if you do not send the articles, we will not release the SAMS newsletter. I want the SAMS newsletter with the voice of all the members of SAMS and the ISA. And I can see this dream coming true because the response this time was overwhelming. Initially, I didn't get the articles, but when I started getting, like, everybody was so enthusiastic and they started sending many articles. So, like, I was very happy, very happy. As you can see in this index, so many branches have participated, and it's really, a dream coming true. And I can see SAMS newsletter becoming the voice of all the members of our state. and I welcome you all to this Sam's newsletter with this flower, which is the flower of Maharashtra, Jarul. And thank you all, and I am looking forward to enthusiastic participation for the third edition of Sam's newsletter. We'll be announcing the branches later. Thank you, sir, and thank you all.
Thank you, Parna ma'am. I'm very happy that Parna ma'am is keeping her word to release the issue of the SAMS newsletter every 3 monthly, and she is doing very nice, and she is taking hard effort for that. Thank you very much, Parna ma'am. Now we will switch over to the today's topic, that is recent advances in chronic and acute pain. Before to start the lecture, I would like to request Dr. Avinash Bhosle sir to introduce today's moderator, Dr. Siddharth Verma sir from New Mumbai.
Thank you, Dr. Rajesh sir. First, I congratulate Dr. Parna for this newsletter, and I also congratulate all who has contributed to this newsletter. Thank you. Now, it's my pleasure to introduce today's moderator, Dr. Siddharth Verma sir. He is an endospine and pain physician. He is MD, DNB, PDCC. He has done fellowship at USA, Spain, and South Korea. He is associate professor in Department of Pain Medicine, D.Y. Patil University, Mumbai. He is founder at Pain Asia, India, and Mumbai Pain School. He is mentor for Pain Medicine Fellowship at D.Y. Patil University, Mumbai. He is consultant endospine and pain physician at multiple hospitals in Mumbai, MGM New Bombay Hospital, Vashi, Apollo Hospital, Navi Mumbai, then Dr. BMH, Railway Hospital, Baikara, and Masina Hospital, Baikara. He has 6 international publications with him, and he is an editorial board member of Indian Journal of Pain. His areas of interest: spine endoscopy, then cool RFA, regenerative medicine, artificial intelligence, and simulation. He is the president of ISA Navi Mumbai City Branch and is joint secretary Indian Society of Pain and Clinician of Pain Clinician. Is GC member Indian Society of Study of Pain. He is associated with many professional association like ISP, ISA, ESRA, VIP, WIP, ISPC, ISSP, RSACP, and ICA. I welcome Dr. Siddharth Verma sir. Over to Dr. Rajesh sir. Thank you.
Yes. Thank you, Avinash sir. Welcome, Dr. Siddharth Verma sir. Now, I would like to request Anita Anaesthesia ma'am to introduce Dr. Samarjit Dey sir. Dr. Anita ma'am.
Thank you, Rajesh. Dr. Samarjit Dey, I welcome you all to Sam's webinar, and he is a very accomplished person. He is a professor in charge pain medicine in the unit of AIMS Mangalagiri, Andhra Pradesh, and also has many other positions in the hospital. And he's editor-in-chief, Indian Journal of Pain, editor-in-chief of Journal of Musculoskeletal Pain. So in very short stint of 12 years, Dr. Dey has many feathers in his cap, and we are really looking forward to listen to you, Dr. Dey. And I welcome you to Sam's webinar. I request Dr. Samarjit Dey to please start with your lecture, sir.
Thank you, madam. Am I audible? Am I audible?
Yes, sir. Dr. Samarjit.
Okay, I'm sharing my screen. Sir, due to some technical steps, I'm not able to share my video.
Yes, Ganesh, can you help?
If you are seeing my screen, please let me know.
Yes, sir. Yes.
We can see your screen, sir. Please
Yes, we can see.
convert to the presentation mode. Yeah. Yes.
So very good evening to all of you. Special good evening to my friend Siddharth. And at the outset, I want to thank Dr. Rajesh for inviting me for this webinar. Initially, when he called me 3 to 4 days back, I was in a dilemma whether to go ahead with this or not. Then this topic was very close to me, and Siddharth have worked hard for this one of the article in IJ for this same topic. So I said, okay, we will do it. So I have been allotted this topic for 30 minutes, but recent advances in chronic pain is happening, is one of the hot topics. We can talk for hours and hours, but in a nutshell, I'll give an overview of the recent advances in chronic pain. So greetings from AIMS Mangalgiri, Andhra Pradesh. This is the institute I work in a beautiful location. Now coming to my topic, I will be covering this topic in this headings, the recent advances for chronic pain under epigenetics and gene therapy, regenerative medicine, neuromodulation techniques, endoscopic spine procedures, nanopeptides and reactive oxygen species carriers, vertebral augmentation techniques, telemedicine and digital health, and artificial intelligence. Coming to epigenetics and gene therapy, which is the talk of the town these days for cancer therapy, this also has affected the pain advancement to target the specific genes for treatment of pain for specific disease has come up very well. So there are multiple phase 2-3 trials are going on for gene therapy. However, there are some ethical issues to conduct such studies in India. But in US, a lot of studies are going on gene therapy for pain treatment. So if we can look into it in a general term, gene therapy, it can be classified into 2 types. One is somatic, one is germline. So somatic gene therapy, it will aims to treat the patient directly without altering the genetic makeup. But for germline, there may be change in the genetic makeup. So if we see for pain conditions, we will not be trying to change the genetic makeup. So germline therapy is what is more important for gene therapy in pain medicine. Now there are various other than these 2 techniques which has been tried and tested, and still the research is going on. However, there is no clinical evidence which is better. So there are some other methods like direct injection of DNA, then liposome mediated DNA transfer, the use of retrovirus vectors and site directed recombination, artificial chromosomes, etc. These are all in trials. So just for knowledge, we can actually, it's good to know. But studies have shown the use of gene therapy to inhibit nociceptive transmission at supraspinal. This one study 2 years back, which is actually creating a lot of good hope. Now targeting various points along the pain pathway, like primary efferent neurons and their synapses, as well as second order neurons inside the dorsal horn, are in trial. Now to deliver the analgesic genes in the nervous system, so there are 3 gene therapy approaches which have been used. So cell-based therapy, plasmid and oligonucleotide, and viral vector gene therapy. So for viral vector gene therapy, which is more popular, it makes use of viruses in their capacity to transmit the infection for their genes to be expressed by the host cell, so that we can treat the painful condition. Now, gene therapy has its own limits, such as dosing, safety, efficacy, apart from other drawbacks, technical or ethical issues, which also has to be considered. Now, although cancers are effective gene carriers, they again have certain drawbacks. To improve the specificity and assess the injury and nearby healthy tissues, the field research must be an efficient gene carrier. This is very much well documented. I will not say this is recent advances, but yes, we have come a long way in regenerative therapy in pain medicine. and we all know that TRP is the talk of town, or talk of the town, and we are using it abundantly, and we are generating evidence even in India. So the effects of anti-inflammatory injections. So ideally, I don't use the word injection. We use the term NIPSI, minimally invasive pain and spinal pain interventions. But this I have taken from an article. So that's why I'm referring to injection. So anti-inflammatory injections in traditional pain management wear off after a few months. You give a steroid and the effect goes off, patient comes back to you, and patient loses hope and goes to the other pain physician, or let's say other physician. So regenerative therapy, it improves the hope and as well as prolongs the management. Now, the powerful regenerative cells and growth factors from the patient's own body is being used, and it stimulates and accelerates the body's natural ability to repair, rebuild, and regenerate its soft tissues. So there are various regenerative therapies, and before that, we would like to see what are the areas where the regenerative therapies are being groundbreaking evidence they are bringing. So low back ache due to degenerative intervertebral disc, pain arising from knee osteoarthritis. There are a lot of systematic reviews and evidence. Shoulder pain, neuropathic pain, and various tendinopathies and fasciitis. So there are various types of regenerative therapies, but out of them, PRP, that is, and growth factors like mesenchymal stem cells are promising. So the ability to activate the intrinsic regenerative pathway and exert an anti-inflammatory effect had made these two the main pillars of regenerative medicine.
Sorry, sir, for interruption. The voice is not clear. Everybody is getting that problem, or only I? Hello?
Can you hear me now?
Actually, the voice, Dr. Samarjit, the bandwidth is low, I think. Though your video is also off, can you try joining from some other, like laptop or something?
I have joined from laptop only, but I'll try again.
Voice is cracking, sir.
Voice is
Yes,
cracking.
बँडविड्थचा प्रॉब्लेम आहे मॅडम इंटरनेटचा त्यामुळे तो प्रॉब्लेम येतोय.
Yes.
I will connect to the hotspot and see.
Yes, please do.
Yes, sir, that's all.
So meanwhile, shall we stop or to do? Because really it's not.
We are not getting the words
Not getting
properly.
Yes. Dr. Siddharth, meanwhile, we can, we can decide whether we wait for 2-3 minutes for Dr. Samarjit to join.
So, Dr. Samar, how much time are you going to take so we can meanwhile decide if we can?
Yes, sir. Your voice is absolutely clear.
Yeah.
Can you hear me now?
Yeah.
Yeah, it is okay. Samar, you can continue like this.
Somewhat better than the previous one.
I am connected to the hotspot, so I think it is better now.
No, again it.
No, again it is break.
Okay. Shall I disconnect and join again?
It is.
Yes,
It must be a problem with your mic, sir.
Maybe a mic problem. Are you using headphone? Remove the headphone.
Are you using Bluetooth, sir?
The mic is in Bluetooth. I have disconnected that.
Disconnect the Bluetooth and just shift your laptop nearer.
Laptop microphone.
I have done that. I have just done that.
Switch to your microphone, laptop microphone. Sir.
Okay, just give me 2 minutes. No, I'm on laptop microphone only now.
I think disconnect and connect because your screen is absolutely clear. So, I mean, there is nothing like we never missed your slide. We wait for a couple of minutes. If we can join in, it's okay.
Yes. Yeah.
Otherwise, we can go to Dr. Umesh's talk first.
Sir, till we can have some discussion. Can we have some discussion? Siddharth, sir, what is your experience at abroad during your
Gene therapy, sir.
yeah,
Pain.
particularly?
So I don't think I have experienced gene therapy in particular, but then definitely the other treatments which he was talking about, that is very common now in other countries. And the major difference which I have seen is that their public is very open to, you can say, the procedures. And even for injections, Indian people are just thinking whether to give or not, and likewise. But that is not they're very low threshold for procedures. Like if you go to Korea, they have like 20 procedures, 25 procedures immediately done. And so one consultant is there, and then there are a lot of patients waiting, and then immediately they get the procedures done. They don't wait for like 10 days, we'll think, we'll tell you, and like that. So probably that is a major difference in terms of I mean, what I see in the Indian system versus the other systems that's there. Samar, can you speak now, Dr. Samar?
Yeah, am I audible?
No,
No,
same.
no. Sir, same problem is there.
It is like we cannot hear you in one voice. Like it's 3-4.
Yeah.
Dr. Sanjit, have you joined from two devices at the same time? Please discontinue from one device. There is
Yes,
echo also. There is echo.
It looks like there are two devices. Yes, that can be the thing.
Yes, that can be there.
Okay.
What is your experiences, sir, in Spain and USA?
So when you talk about United States, their system is quite focused on the insurance, and that is a major system. If something is covered, then only it gets done, and they have specific. They've spent a lot of time to create that system, and in fact, the physicians also spend a lot of time in filling those stuff. Other than that, the spinal cord stimulation is something which they are doing at a very high rate, which is almost zero in India. Like we are doing like 50 cases in 1 year, and they are doing some 30,000, 50,000, this kind of cases in 1 year. So this is a huge gap.
Yeah.
Huge gap, and it remains to be fulfilled. Then pain medicine as a branch there is fed by doctors from PMR, from anesthesia, majorly from anesthesia, and then also from other specialties. And there is no fight, like, I mean, who is doing this procedure and that procedure. It is limited to the society level. Individual doesn't have to like fight on that, and the society is taking on the other hand, in India it's on one person that he starts doing one procedure, then two start doing, then three. So it's a bottom up approach, which is quite different. It creates a lot of difficulty for the individual practitioner. So the awareness for pain is much higher in terms of chronic pain. For acute pain also, they are doing much better. And in fact, the surprising thing is cancer pain interventions in other countries are much higher as far as comparison with probably India, and especially my portion, like Mumbai is basically, or Maharashtra in general, because we follow mostly the Tata model, and as a result, there is a lot of that is a prime institution. So the oncologists and the oncosurgeons, what they learn there is what is followed throughout. On the other hand, if you go to the north side, probably somebody who's done from is there from AIMS or something, the interventions, cancer interventions are quite higher. For example, Tata Memorial Hospital in Mumbai doesn't have an RF generator. So that's a very surprising, I mean, thing. Anybody from Tata here in this group today can just corroborate. So this is a major difference. Okay, Dr. Samar, are you there? Or I think we can continue with the second talk, so that for the interest of audience.
Yes. Umesh? Dr. Umesh?
Dr. Umesh, are you there?
Yes, ma'am. Yes, sir.
Can you start
Oh,
Okay.
your screen?
If you are
no,
ready,
who is
please.
introducing Dr. Umesh?
Yes.
Yes, I am
Dilip.
introducing, sir.
Dr.
No,
Dilip.
please
Yes,
introduce.
yes, yeah.
Yeah, okay.
Yes. Hello. Oh,
Yes.
yes.
Yes,
Dilip.
please continue,
Yes,
sir.
yes, Dilip.
Ganesh, can you put the slide?
Yes, sir. Yes. Now visible, sir.
Yeah.
Yes, yes.
Yeah, very good evening to everybody. Today, it's my pleasure to introduce my senior colleague, Dr. Umesh Ramtani, sir. He is MBBS MD Anesthesia, and he's having a pain fellowship with him. And he's currently is working as a associate professor anesthesiology, Government Medical College, Nagpur. And currently, he is president-elect for ISA NCB for the year 23-24 and honorable treasurer for the Society of Pain, Nagpur. He is a postgraduate teacher since long and having experience of around 16 years. He is having many national and international publication to his name. And also he has received many awards at both national and state level. And he has been also faculty at various national and state level conferences. And he is having keen interest in chronic pain and regional anesthesia. So we welcome you, Ramtani sir. You can start your lecture. Thank you.
Yes, recently Umesh had done a good job at Mahayuvakon. It was a grand success.
Yes, yes, sir.
I have seen that. Okay,
Yeah, he
please
was the
continue.
organizing chairman for the third Yuva
Yeah.
Mahapan 23 Nagpur.
Yeah.
Umesh, go to slideshow and start from beginning.
Yes, ma'am.
Or just scroll up the slides.
Go to first slide. Yes.
Presentation. Yes. Yeah. Yes. We can see your slide. Yes.
So, thank you, Dilip, for this kind introduction. Respected Balaji sir, Anita madam, Rajesh sir, and other office bearers of SAMS. First of all, I would thank you for giving me this opportunity and congratulate the SAMS body for selecting this very, very important topic. Actually, Dr. Samarjit was supposed to cover the chronic pain. So as such, chronic pain or acute pain, whatsoever is this, it is not merely a symptom, it is a disease per se because of its multi-systematic consequences and multimodal involvement. So timely, appropriate and complete optimal treatment of acute pain there and there is crucial because if it is not done in the proper way, that acute pain will convert into chronic pain ultimately, and the consequences will be dangerous. So what actually is the acute pain? We as anesthesiologists are basically concerned about perioperative pain as acute pain. But as pain physicians, we anesthesiologists are having another moral and ethical responsibility of controlling the pain from other diseases like post-traumatic pain or some medical diseases, musculoskeletal pain, inflammatory origin pain. So there are various forms and causes of acute pain. Some hyperacute conditions like labor pains, pains due to cardiac origin, some sickle cell crisis, as Nagpur belt is a sickle cell belt. So we receive so many patients of sickle cell crisis. And there are various surgical causes to acute pain also, like acute abdomen, pancreatitis, renal colic, and vasculitis. These all are to be considered equally. So we cannot confine ourselves as perioperative physicians, but as a pain physician, we should tackle these acute pain varieties systematically. As far as types of pain are concerned, mostly these acute pain is a nociceptive variety, but definitely always any type of pain has a neuroendocrine component to it. So acute neuropathic variety of pain is a gruesome disease itself. So I repeat, acute pain is not merely a symptom, it is a disease. If it is not treated, it will become a nuisance. And it is our moral and ethical responsibility to relieve pain, and any failure should not be considered good. And human beings have a right to get pain relief. It should be part of our duty of care. So relief of pain should be a human right. So as we all know, the field of medicine is full of advancement. Day on day basis, the medical science is getting updated, getting advanced, and so is the pain medicine. We are witnessing so many advances in acute as well as chronic pain management strategies. Now, these societies are working hard for this. Like this American Pain Society and American Academy of Pain Management had set up a task force in 2016, which had established diagnostic criteria for acute pain. Now, what they did, they developed a 5-dimension approach. What they said that we have to describe what is inciting the acute pain, what is the type of injury, what is the causative agent, what is the pattern of onset of symptoms and signs of acute pain condition. And we have to emphasize on common features, signs of acute inflammation, and whether there is temporal, spatial, or anatomical distribution to pain, because it will help us in anticipating the recovery. And as I said, that the neuroendocrine component is very, very important. So the putative mechanisms have to be understood. And we have to empathize with the patients because pain has significant impact on functional component of life of patients. Pain can be catastrophizing, and it has significant physical, social, and mental consequences. And there are various modulating factors to pain. So we have to understand basically the pathophysiology of acute pain so as to treat it properly. And on the basis of this associations have developed a comprehensive approach, and they have remodeled the pain management guidelines. There are various age-old mechanisms of treating pain, and since centuries of medicine, we are using those drugs, those non-pharmacological methods, but recommendations are numerous, and few of the recommendations target on multimodal analgesia, which is very, very important because pain itself is a multimodal concept. Even if it is acute pain, it has a multimodal concept. So to treat it, to completely recover from it, we need multimodal analgesia. We have to start with non-pharmacological methods. We have to use NSAIDs, but as we all know, NSAIDs are dangerous. So the advances are required for more safer drugs in this field. Urexil analgesia has seen alarming advancements in last decade. In last 10 years, we have seen multiple newer strategies and modalities of regional anesthesia. So I will discuss them in my next slide. And nowadays, there are certain recommendations for surgical site-specific strategies also, which, for example, laparoscopic surgery. We have to inject port injections. We have to infiltrate the peritoneal surfaces with local anesthetic. There are many fumescent anesthesia techniques. There are various regional blocks for that also. There are various infiltration methods also for treating such conditions. So these remodeled pain management guidelines are available with us for most advancements in pain medicine, and we can adopt these newer strategies for our patients. To understand completely, as I already said, we have to understand the entire pain pathway. Now, not going much into details of this, but at least to highlight, pain mechanism is involving peripheral nociceptors, then spinal level, there are various neural mechanisms, and then from the brainstem to the midbrain and to the somatosensory cortex, everywhere the relay is important, and the limbic system involvement explains the neuroendocrine component or psychosomatic component to the pain. So this becomes the basis for multimodal pain management. ऐसा नहीं चलेगा कि पेरिफेरल पेन है, उसको एक गोली दे दिया कि हो गया काम. No, we will have to target the pain completely. by multiple ways. From all sides, we have to target the pain. So I will discuss these multimodal pain modalities and what are the advances associated with this in my future slides. Now, as far as non-pharmacological methods are concerned, they are also very, very important, and there are various advancements in this field also. Now, there are, as we all know, these age-old acupuncture, TENS, physiotherapy, these are already existing. But in these, there are certain newer modalities coming, like we have, in our institute, we have non-invasive radio frequency. So it is giving good results. There are high-intensity laser therapies available. We have deep tissue lasers. We have IMS, muscle stimulators, dry needling is coming. Research is going on to prove these non-pharmacological methods which will assist in achieving pain relief. So ultimately, multimodal targets are there. We have various drugs which target at various levels. And ultimate purpose is to break the pain cycle so as to achieve the pain relief. So to start with, basically it is age-old saying that prevention is better than cure. So we all know about preemptive analgesia. As anesthesiologists, we use various agents in OT to achieve preemptive analgesia. What they do, we inject certain drugs, for example, ketamine we are giving. So what it achieves? It achieves the pain, it achieves pain relief by targeting before the onset of noxious stimulus, before the surgical stimulus we are giving these drugs. But what it lacks the target of central sensitization. It forgets it. So what we need for this central sensitization to be controlled, we need a broader scope of approach. And how can we achieve? We have to do preventive analgesia. So this is the newer concept. This is the advancement in the prevention level. So we have to shift from preemptive analgesia to the preventive analgesia. What it does, it basically, this acts at the all levels of, from the pre-incision to the reversal level. It maintains the analgesia, and so through central mechanism, it achieves analgesia for the long time. And ultimately, that hypersensitivity to the stimulus, noxious stimulus, is decreased. So we have many drugs in this for this purpose. Like we use paracetamol infusions. Nowadays we are using gabapentinoids orally preoperatively. We start from preoperative and then we continue up to the postoperative period. So that also achieves preventive analgesia. Sometimes we use Loxigard infusions in perioperative period. So these Loxigard infusions have good results in preventive analgesia. So ultimately, preventive analgesia is a growing concept, and we should utilize it properly. So as far as non-operative pains are concerned, pains due to medical diseases, generally we use pharmacotherapy. As pain physicians, we follow this WHO stepladder. So at every level, we have different drug formulations, different pharmacotherapy. But now, what advances we require in these? Because these pharmacotherapeutic agents are full of side effects. They are having so many other renal harmful effects, gastrointestinal harmful effects, and organ dysfunction is there. So we need advances in that. So now these are the newer modalities of drug administration. So what we have done, we have changed the routes of administration for better safety and for better action. Now we all know that जब patient आता है, suppose उसको knee pain है, arthritis है, osteoarthritis है, we will start with oral NSAIDs or paracetamol for that. But now we know that this patient is having some creat levels are higher. So we need some better drug. So what we will do, we will use certain specific COX-2 inhibitors who are having better renal profile. Now these COX-2 inhibitors are having a targeted approach. Now this lumiracoxib is very highly potent newer drug, and nowadays it is having role in chronic pain also. Then we have various other SNRIs who are acting on serotonin norepinephrine reuptake inhibitors. We commonly use them in chronic pain, but they have a role in acute pain also, because central sensitization is involved in acute pain mechanism also. So we use venlafaxine, we use milnacipran, we use duloxetine. We are using them in acute pain as well. Then we have anticonvulsants. They act on GABA mechanism, like gabapentin, pregabalin, lamotrigine, So these all are newer and safer oral drugs. Now, if we want to step up our therapy, we will use IV drugs, and then we can use PCA devices. We can add up to opioids, and Nefopam is an NSAID, which is a newer drug, which is very promising. And then there is iontophoresis, which I will discuss in next slide. This is a transdermal method of drug delivery. Transdermal patches, as we all know, fentanyl patches and all. I will discuss in next slide. The one more route is there, which is pulmonary. We have aerosol preparations of drugs, which can be administered safely, and they have a very excellent result. Now there are microspheres. There are microparticles which we can give them. What happens? We give these drugs orally. The gastric juices dilute these drugs, and effect is bioavailability is decreased. If we give them in an encapsulated microspherical particle shape, so they will be absorbed better. We have sublingual sprays, nasal sprays, specifically for pediatric groups, because pediatric patients are non-compliant patients. They cannot swallow, or they cannot take tablets. So in nasal opioids are also giving good results. So these are the different routes which I will discuss in next slide, by which we can increase the safety profile, we can increase the effect also. Now, regional anesthesia, as I already said, GARA is the most promising method of achieving perioperative pain. So in all type of major surgeries, we are using the various regional anesthesia techniques like nerve blocks, TAP blocks we are giving erectrospinal block, we are giving quadratus lumborum block. What is new in these fields? Because this is the most fastly growing field as far as our anesthesia field is concerned. So we have newer drugs. Again, safety profile is better with levobupivacaine. Research is going on. And then we have liposomal preparations, which are given in peritoneal surfaces, in anterior abdominal wall, and ropivacaine. Though it is an old drug, but now the benefits of ropivacaine are recognized, and we are using them very vastly because of longer duration of analgesia. And then came the USG. The USG is the third eye of all the anesthesiology. So various newer regional blocks are available. With the help of USG, we can achieve them, like facial plane blocks, SIFI blocks, PENG blocks. In orthopedic surgeries, they prove to be miracles because they provide instant pain relief during positioning, during shifting, during administration of anesthesia, and also in the postoperative field. There are going further in this technique, we have IPAC block, like in infiltration of drugs between popliteal artery and capsule of knee. This we are trying in our institute. So it is giving good results, because in knee surgeries, adductor block, if we are giving in TKR, the posterior component is spared. Pain in posterior component is not achieved by adductor canal block. So by IPAC technique, we are achieving that. There is one high-pack technique also, which is called as high volume block of proximal adductor canal. Again, the same problem of sparing. Obturator component is completely spared in normal conventional adductor canal block. With high-pack technique, we can achieve that also. Again, similarly, subsartorial infiltration of drugs. So these are only possible because we have USG assistance. We can easily perform these techniques. Otherwise, they were not possible. Now, we know that interscalene blocks or other nerve plexus blocks are associated with damage of vital structures. So for that, we can give intracluster and intratruncal blocks. What we do, we select certain 5 or 6 cluster points around the plexus, and we inject drug over there. Then diaphragm sparing blocks. This is one of the side effects of upper limb block. So what we do, we achieve costoclavicular approach, we do infraclavicular approach, or we do lateral paravascular approach of supraclavicular block. So their diaphragm is spared. So this is a huge benefit, again, due to a USG, thanks to USG. Then comes the continuous peripheral nerve blockage. Now, nerve blocks are routinely done by all anesthesiologists, but now we have contiplex catheters, we have intraneural elastometric pumps. So ultimately, these are connected to the catheters we insert in the nerve plexus area, and we can continuously inject the drugs in infusion method. and we can prolong our analgesia for up to 72 hours or even more than that. And segmental spinal is again a boon to us, but along with general anesthesia, we can mix it for analgesia. Very much in use nowadays in ICUs also, or in other in bigger institutes. We are using these pre-filled syringes. These pre-filled pumps are there, which we are attaching to the line is attached to the PCA device, and patient has this button. He can switch and inject the boluses, or even the breakthrough pain can be controlled with this. Going more ahead, this is the entire system of PCA devices, which can be used specifically in labor analgesia or in some major surgeries, which we can use. Even in cancer pain, we are using this technique too. Similarly, these portable pumps are there where patient can take these pumps to home and continue with his analgesia regime, especially cancer pain. These are elastometric capsules where their pre-decided amount of drug is injected, and that collapsible bag will inject the drug through epidural catheters also, and also through intravenous methods. These are the elastometric pumps. Now this is what I was talking about, continuous peripheral nerve blockade. Now, these are Contiplex catheters. The Contiplex method, through the needle we insert under the USG guidance, and then the stellate is removed and the catheter is inserted inside. These are the marked catheters, and they are fenestrated. Other route which I was discussing, like transdermal administration, how it acts. This is a multi-layered patch which has membrane, which has drug levels, and then they have a over covering it is, and when it is applied over the skin with a pressure, the controlled and fast release methods are available through this particle system, and the sustained release drugs are there. So toxicity is also avoided, and sustained release prolongs the anesthesia or analgesia for longer duration effect. We have many opioids, lidocaine plasters, ketorolac patches, NSAID patches, buprenorphine patches, utilizing the same technology. Other routes, transmucosal, fentanyl citrate. It is very popular in chronic pain practically, but in orthopedic pain, it also provides good pain relief. I already talked about transnasal sprays, because in pediatric patients, they provide excellent method of administration. Rectal routes, we have transpulmonary aerosol preparation and sublingual routes. Now, iontophoresis, which I was talking. Now, this is like a plaster, which is having a battery inside, and a button is there. When we on this button, there are electronic circuitries activated, and this is a drug area, and using this electronic circuitry, this drug is released from here. This is a simple device, जैसा अपना finger pulse ox रहता है वैसा ही रहता है. This can be attached to the patient's abdomen, anterior-abdominal wall, and they can switch on and off this according to the regimes advised by the physician. So these are the newer techniques. Fentanyl preparations are coming, or even lignocaine we can use using this. Ketamine we can give through this technique. So this iontophoresis is again a good technique, newer technique. Research is needed to prove this more, and slowly we'll come to know about the benefits and harmful effects. Now there is extended release encapsulated morphine preparation. These are again very much valuable in acute on chronic cancer pain, because cancer pains have many acute exacerbations. So there we can use these. These are directly delivered to the periphery of the lungs. These are aerosol or aerosol preparations of morphine or fentanyl. They are also under research. Aerosolized liposomal preparation. What is the best benefit of this? Because pulmonary surface area is very large. If these reaches up to the pulmonary area, the absorption will be very good, and extended release of drugs will be possible, and patient will be pain-free for weeks together. So ultimately, the advances require further study of various receptors. Now, how these gabapentin and pregabalin act? They act on alpha-2 delta modulators. So they alone will not be acting. So we will use them as adjuvants. We will combine them with these other drugs and we will achieve their effect. There are various GABA analogs which are coming in the market. Newer research is going on. These GABA analogs will also work on the same principle. As I've already told you about SNRI, because central sensitization has to be controlled. Then and then only the complete recovery from acute pain will be possible. Otherwise, we will leave that aspect and that will be converted into chronic pain. Purpose will not be solved. So SNRIs like milnacipran, duloxetine, venlafaxine, and other nortriptyline and other combinations are available, which are used in chronic pain moreover, but acute pain also requires these combination therapies as adjuvant. Ketamine has its own excellent effect. We know all that, like NMDA antagonism, which is again controlling the central sensitization. How ketamine is helpful? It is helpful in preemptive analgesia. It is helpful in preventive analgesia. It is helpful in PCA devices for cancer pain. It is helpful in other pains of fibromyalgias also. Calcitonin, I use it very much because I receive patients of parathyroid disorders and Paget's disease of bone, and ultimately this calcitonin will act through in osteoporotic pain patients who complain of pain. So calcitonin is also having a good result. So only the cost is a factor, but otherwise it's a very good drug. Recently, I've been using cannabinoids. These cannabinoid drops are available. They act on CB2 receptors. CB2 receptors are present in spinal as well as supraspinal level. So these cannabinoids have a lesser abuse potential, but a better result in acute pain. It has role in migraines. It has role in acute headaches also. Also in inflammatory pain, arthritis pain. These cannabinoids have low. Even locally applied cannabinoid suspension solutions are available. I order them. Only the licensing and everything is required because these are ultimately cannabis preparations. But they are also coming in the market and they have good results also. So we have to target various receptors. The research proved that there are various receptors responsible for various actions. And if these receptors and their antagonists are studied well, they can be used for pain relief. Now, this TRPA1 receptor is present at nociceptive level, peripheral level. So capsaicin, lidocaine plasters, they act through this TRPA1 receptors. CB2 receptors, I already told. GABA A receptors, GABA analogs are available. There is one more, imidazoline receptors. The study proved that various diabetic neuropathies or various peripheral neuropathies, the imidazoline receptors are responsible. So if imidazoline receptor antagonist comes into market, they will have benefit in diabetic neuropathy. A word about opioid epidemic. Now, as we are anesthesiologists, we are using opioids rampantly. We should understand that in US, there was an opioid epidemic and they have passed certain regulations. So nowadays, the recent advances are moving towards opioid sparing anesthesia and analgesia. So abuse deterrent opioid formulations are available. What we can do? We can use lower opioids or we can use synthetic opioids to treat this problem, like methadone. What is having? It is having additional NMDA antagonistic property. So methadone, what it will cause? It will avoid that opioid crisis. Similarly, naloxone and naltrexone will act. Or otherwise, we can use slow release formulation, which will not cause significant abuse, or in the microparticle fashion, so that opioid abuse or opioid dependence is decreased. A word about special situations. Labor analgesia, many advances are going on. We have PCA devices, we have continuous epidurals, we have walking epidurals, we have tab blocks. Again, we have regional blocks. Some non-pharmacological therapies are available. There are water therapies, water jackets are available, hot water jackets, and many other. Garba Sanskar is again being studied. Ultimately, this labor analgesia also is going to be a very big subject itself. Sickle cell crisis, I receive many patients of sickle cell because Nagpur is a sickle cell belt. Patches work dramatically in sickle cell. Fentanyl patches, buprenorphine patches, they have good results. If patient is having renal disease, of course, we have to titrate our drug. That's why COX-2 inhibitors. Now, paracetamol, it was considered to be safer. But nowadays there is a recent advance. It is having a nitroxy paracetamol is being studied. It is again a further advancement. It is more hepato safe, liver safe, and renal safe drug. Similarly, tapentadol is available. They say it is again safe as far as organ dysfunction is concerned. Pediatric population, we have to consider certain routes of administration like nasal, rectal, and so on. Geriatrics, again the problem with metabolism, compliance, cognitive dysfunction, and definitely chronic comorbid condition. So we have to keep in mind when dealing with these special situations. But we cannot fear of saying that acute pain should be left out. We should not leave the pain as it is. It is our duty to provide relief to the patient. In future, what we are having nanotechnology, we are having artificial intelligence. Artificial intelligence will work at every level, starting from diagnosis up to the policy making and then to the treatment and complete rehabilitation. So let's see what is there. So these are my references. Basically, again, I repeat, pain is inevitable, but suffering is optional. All you really need is hope and strength. We should not leave our hope. We should hope for the better change, and we should be strong enough to hold on until it does. Thank you.
Thank you very much, Dr. Ramesh. So, ma'am, if you allow, we can go to Dr. Samar's presentation, or do we have the Q&A first?
Yes, ma'am. Yes, sir. We'll go for second lecture.
So I think Dr. Samar, are you ready with your?
Yeah, I'm ready now. I'm going to share my screen. Am I audible?
Yes, much better.
Right. So I'm connected through phone now for audio.
Okay.
Yeah. Okay. As I have, good evening everyone. Again, sorry for the glitch. It was not expected. So as I have already discussed the gene therapy, I will start with the regenerative therapy. Now coming to stem cell therapy in regenerative therapy. So stem cell therapy again is making a lot of evidence these days for chronic pain conditions. And stem cell, as you know, that from various tissues we can culture stem cells, especially bone marrow tissue, which contains rich amount of stem cells. And stem cells can become almost any kind of tissue in our body, including bone, cartilage, muscle, tendon, and ligament. So the idea of stem cell therapy, there are two ways. You can convert it to an organ or to help regenerating tissue or part of a tissue. So our idea is to regenerating a part of a tissue, which is a pain generator. So these adult stem cells, they play crucial role in renewal and repair of the injured tissues or organs. So the unique ability to make them highly valuable for treating numerous pain conditions such as osteoarthritis and tendon injuries. These are the two indications where stem cell therapy has come up in a big way. Now, adult stem cells, they can be classified based on their tissue of origin, including those derived from like placenta, umbilical cord, hematopoietic stem cells, mesenchymal cells derived from bone marrow or adipose tissue. So there are various types of stem cells, and these days there are some regulatory issues to use stem cells. You should have a stem cell unit. However, some companies have come up with portable stem cells to use in various conditions. Now, stem cell therapy, it may effectively address the neuropathic pain-associated conditions like any sciatic nerve injury or any nerve injury, diabetic neuropathies, spinal cord injury, trigeminal neuropathy. These are the conditions where various trials have been done, and some sort of good results are there. We cannot say that it is very much effective, but yes, we need to further investigate. So mesenchymal stem cells, they are promising in low back pain, and it is quite useful because various degenerative diseases there, which are like, for example, disc degeneration is one of the main conditions, and it is becoming an epidemic. So what they have done is various studies, various trials, they try to culture mesenchymal stem cells obtained from the bone marrow and then try to co-culture them with nucleus pulposus so that they can regrow similar type of tissue and put it there so that the disc degeneration can be controlled. So processing of mesenchymal stem cells, So usually what happens, it is harvested from bone marrow and or adipose tissue, wherever we take it from, and then expanded in vitro cell culture. So culture expansion is performed, and then it is centrifuged and resuspended in ice cold collagen fibronectin gel. And this gel, it forms a soft gel at body temperature. So this can be injected. This mixture can be injected to target tissue. So the choice between allogenic and autologous stem cell types needs to be carefully considered for appropriate use. As we know that autologous is from the same body and allogenic from the other. So there should be various consent as per the protocol of the institution or the hospital to be followed. So there are very few human trials in relation to stem cells in pain and pain medicine. But yes, there are many phase 1 or 2 trials going on. And one of the most important parts is to come up with the proper doses, safety consideration, and implantation rates, which is necessarily effective for therapeutic application. And one major drawback for stem cell therapy is, which has come up, is teratoma, because if the vascular not correct, so there are many applications and many phase 2 and phase 1 trials, and we can see that most of them are in low back pain and diabetic neuropathy and shoulder also, knee osteoarthritis. So we can see that there are various site applications. So shoulder, knee, low back pain, and again peripheral neuropathy like diabetic neuropathy, they are trying to regenerate the tissue. Coming back to our own favorite platelet-rich plasma, it has come a long way, and I'm sure most of the institutes, when they start with regenerative therapy, they start with platelet-rich plasma. Advantage being that the blood bank can process that PRP for us and give it to us. However, we should also have our own centrifuge and try to process the PRP so that infection protocol is followed, because then and then in the operation theater itself or the intervention suite itself, you can collect the PRP and inject at the specific site. So as the name suggests, PRP, there will not the concentration of platelet, the high concentration of platelet will be injected. Why? This has a lot of pro and anti-inflammatory mediators, growth factors. So the natural healing is being accelerated. Now, when you inject PRP into the damaged part of the body, so you can expect an initial increase in inflammation and swelling, and subsequently it tries to heal the tissue and gives us the pain relief. So the initial part may be painful. The night immediately after injecting the PRP, so we need to counsel the patient and inform them properly. So by reducing the inflammation and supporting the healing process, PRP naturally reduces the pain. So many times for PRP injection, we try to accompany with some sort of nerve blockage, because so that the pain is less. Now PRP preparation, again, we collect the blood and then we centrifuge it, and after centrifuging, first spin, what we tell it, it is divided into two. The upper part is buffy coat and plasma, which is discarded and red cells, and after that the upper part is being taken and then again centrifuge, second spin. So then again it will be divided into two parts. One is the upper part is platelet poor plasma, the lower part is platelet rich plasma. So we have to use the platelet rich plasma. Again, there are various protocols in different institutions, like the count of platelet, which is actually the institution specific, and also where we are using site specific. So there are various sites or areas where the regenerative therapy, not even platelet, even the stem cells, which can be used, like most importantly again ligament sprain and various ligament injuries. The most common is osteoarthritis, various cartilage issues, ligament injuries, partial tears, various tendinitis, ankle and foot plantar fasciitis has we have got a good results, and various tendinitis like Achilles tendinitis. And coming to low back, facet joint arthritis, has come. Degenerative facial joint, isolated facial joint arthropathy is giving a promising result. Sacroiliac joint pain, and then hip pain. In elbow, again, lateral epicondylitis, medial epicondylitis, and shoulder, again, rotator cuff tendinitis and partial tears, which are very useful. Coming to endoscopic spinal procedures, because I have to mention it specifically because we as a pain physician, we are advancing in throughout various interventions, various non-intervention things. But endoscopic spinal procedure is a breakthrough because, again, there are various approaches. So, transforaminal, interlaminar, anterior and posterior approaches, caudal and transsacral approaches. So, we have come a long way for us to provide a safe, direct, and targeted access to the pathology with less soft tissue disruption. So, endoscopic spinal procedure, which is evolving, and it has evolved and still evolving, and we must again actually applaud our Indian pain physicians who are trying. Siddharth is also trying his best to take the endoscopy forward. So the pain physicians are able to actually treat the disease. Now, various neuromodulation techniques, it can start, as we know, that the standard spinal cord stimulation, dorsal root ganglia stimulation, peripheral nerve stimulation, which is again getting a lot of popularity because it is with the application, ease of application, and again we have pooled radiofrequency ablation, neuroablation, etc. The pooled RFA again, and most of the institutions and the private clinics and private pain hospitals, they are using radiofrequency ablation and pooled radiofrequency.
ये आपका अगर एक दो एंडोस्कोपी भी आ गया तो पूरा कवर है।
बराबर, मगर उसके लिए सपोर्ट चाहिए ना आपका ही
Yeah, so when you do a standard radio frequency, what happens? We are ablating the target nerve, and as well as we are also charging the normal tissue. So the cooled RFA helps to control that tissue damage, as well as help us to produce a bigger lesion and give us a proper and prolonged pain relief. Cryoneuroablation, again, it is coming up. The evidence is being generated, and it affects on Joule Thomson effect. And what happens if because of the changes in temperature and pressure, the ice ball effect, one ice ball is being formed. So at the temperature where the nerve, at around minus 20 degrees centigrade, the nerve fibers stop conducting. So the idea is to in transmission. Cryoneurolysis works on this principle. So applying cold temperature to the tissues to create a conduction flow. So the intensity and duration of analgesia is dependent on degree of nerve damage to the ice ball. So in India also, we are using cryoneuroablation in hand with our radiofrequency ablation. But again, if we talk about evidence, how much it is effective, yes, there are less studies and less evidence. It is coming up. Probably in a year or two, we will have more evidence for cryoneurolysis, mostly for neuropathies or specific neuralgias where we can target. So pain relief after cryoneuroablation creates a normal environment so that as the nerve regenerates, original pathology will not happen. Again, there are some side effects of the association pain and neuritis after radiofrequency, which is less in cryoablation. Coming to spinal cord stimulation. So spinal cord stimulation, it is like again, as Dr. Umesh said, epidemic of opioids, other therapies need to be considered. So spinal cord stimulation is one of the last resort before going for surgery, which was actually the the protocol. But again, with the advent of various surgeries like endoscopy, So goals of the care to improve the function, reduce the analgesic medication use as opioids, and improve the quality of life. So these are the leads, and you can check it in the X-ray. And this is the spinal cord stimulator. There are various phases. One is initially we have to give a trial and see whether it is working or not. Then, if the trial is successful, permanent spinal cord stimulator is being applied. So the anti-ischemic effect of spinal cord stimulator provides an opportunity to modify the underlying condition and then reducing the palliation of the pain. So the clinical effects of spinal cord application of spinal cord stimulation, it can be effective in failed back surgery syndrome, which is most commonly used, radiculopathy and phantom limb syndrome, CRPS, diabetic neuropathy, post-operative neuralgia, and peripheral vascular disease. It has moderate evidence. There are various complications like lead migration, lead breakage, device malfunction. You need to be in touch with the company engineer throughout. Infection is one of the very devastating complications if it happens. So it may land the patient into a lot of trouble. Undesired stimulation, etc. Peripheral nerve stimulator, again, it is coming up in a long way, and it is a lot of research is being done to peripherally stimulate the nerve and try to control, because it is actually stimulating the large diameter fibers and trying to control the pain by gate control theory. So peripheral nerve stimulator, what we do is generally we implant, we place the peripheral nerve stimulator and put the lead across the targeted nerve where it stimulates it, right? So then it can be placed under by X-ray guidance, C-arm guidance, or ultrasound guidance, where the precise peripheral nerve we want to target, and electrical pulses generated by the electrodes interfere with the pain signals, and that are being sent basically. So then what happens? There will be discordance and relief of pain. So various conditions, again, peripheral nerve stimulation, again, chronic back pain, headaches and neuralgias, nerve compression, chronic neuropathic pain of upper and lower extremities, persistent shoulder and knee pain. There are where PNS is very much various trials. Another one is dorsal root ganglia stimulation. Yes, again, the dorsal root ganglia stimulation, it was of lot of hype, but these days it has come down. The BRG stimulation has come down, and potentially it was superior in case of CRPS. There are a lot of studies which was done for CRPS where BRG was compared with spinal cord stimulation, and it was found to be superior in trials. So BRG stimulation is applied for the management of various intractable radicular pain or post-operative neuralgia patients and CRPS. Few points about intracerebral stimulation. Stimulation, again, it is currently referred as deep brain stimulation, but these days deep brain stimulation is not being done. So PAG, pediatric aqueductal gray stimulation, it was preferentially supposed to be influenced nociceptive or the mixed form of pain. Stimulation in the posterior hypothalamus was introduced as a novel method treating medically resistant cluster headache. However, this invasive techniques they are not doing these days. They have shifted to non-invasive techniques, and like so we have various motor cortex stimulation, and we have again axon therapy or transcutaneous magnetic stimulation. So this stimulation, it tries to generate small electric currents, and it is hypothesized that pain following cerebral lesion is the result of deficient inhibitory pain control. So activation of the large control fiber reciprocal connections between the motor and sensory cortex by motor cortex stimulation would help in restoration of the inhibitory pain circuit. So that will help us in relieving the pain. And if we go to the axon therapy or the transcutaneous magnetic stimulation, which is specially devised for post-nerve injury where neuromus formation is there to target those disease condition, where again there is inhibitory effects on the neurons and may serve as a viable treatment option for a patient with neuromas. Well, coming to nanocarriers or nanoparticles, so nanomedicine is something which is again at molecular level growing day by day. So nanoparticles, like Dr. Umesh has also already mentioned, various diseases like cancer and all, in pain medicine also, it is providing various transportation of drugs to places where human body they would not normally be able to go. So basically, we are targeting the areas to reduce the side effect of the drugs where the drugs have a narrow therapeutic index. So the main use of nanoparticles in medicine and organic materials such as liposome. So like potentially neuropathic pain. So in recent study in 2023 in mouse models, most of them are animal studies, demonstrated that enhancement of delivery of S-ketamine using nano particle hydrogen delivery system. Again, zinc oxide nanoparticle is another investigation where they have investigated the potential role in to release the zinc ions and relieve the pain. But again, as I said, reactive oxygen species scavengers, ROS, when produced in excess, it causes tissue damage, inflammation, and pain. So, we use a scavenger to control that. Again, it depends on the pathophysiological process in neuropathic pain, it can be targeted through this vertebral augmentation therapy, again, it includes vertebroplasty, kyphoplasty, and very recently, vertebral stenting. Pardon me for the spelling. So vertebral stenting is like, again, putting a stent and expand the collapsed vertebra. So we are very happy to say that the same vertebral stenting is being done in Lucknow by Dr. Anurag. And the current indication for vertebroplasty is injectable non-radicular pain resulting from compression fractures. So after MRI, the targeted vertebra can be approached posteriorly through transpedicular or parapedicular way. Now again, vertebroplasty is one such midstream where we see the patient getting instant pain relief. Many times, if it is a single level, otherwise, then the patient will just they can walk out of the operation theatre. So it's very, very satisfying vertebroplasty or kyphoplasty. Something I have not done, so I have just got the experience from Dr. Anurag that it is also equally effective. Again, there are various complications with such mixes like cement leakage, which can seep into the veins. So monitoring and of such procedures are very important. It should be done in a proper operation theatre with with all standard monitoring. Cannabinoids, Dr. Umesh has already said, and it is coming up in a big way again in chronic pain, and we see a lot of patients who are who actually abuse cannabinoids. So in our anesthesia practice, probably not in chronic pain. So cannabinoids has various receptors to act on CB1 and CB2. CB1 CNS, again CB2 mostly in DRG and supraspinal level. So THC, delta 9 trans tetrahydrocannabinol, is the primary cannabinoid found in cannabis. So it acts at partial level with both the receptors. Now, damage to the nervous system is linked to significant increase in expression of CB2 receptors in the dorsal root ganglion. That is where the role of cannabinoids come. So if we give THC, it will act on CB2 receptors. It will result in increased CRP level, and of course, by reducing the immune system activation, inflammation, ultimately leading to pain reduction. So again, there are regulatory issues with cannabinoids, but again, as far as I remember, Indian hemp company is trying to market it, and we are getting tablets of 2.5 to 10 milligram. And I have not used it personally, but yes, I do listen from my various colleagues that they are getting good result with 2.5 milligram doses, where there is the refractory cancer pain also. Coming to monoclonal antibodies, again, these are all in trials. They are trying to develop monoclonal antibodies target specific ligands, and there are various nerve growth factor and TNF alpha being targeted, and it's still in phase 1 trial or phase 2 trials. Very important, telemedicine. It has actually changed the access and management of pain physicians and pain medicine. And thanks to COVID, where people actually experienced what is telemedicine. So it breaks down the geographical barriers. Now it enables the patients in remote location and all the underserved areas to consult with the specialists. Now, recently we have started our telemedicine services to the district hospital for pain patients. So we are coming up in small steps to try to incorporate this technology in our practice. And this is very useful for India. Why? Because these days the district hospitals are being given a lot of importance, and we all can actually target the telemedicine to the benefit. Now, patients even can do follow, and telemedicine also offers convenience in receiving care from home, which can be especially beneficial for patients. And sometimes mobility is an issue with severe pain. Digital apps or wearables, yes, for enhancing pain management, pain tracking devices are underway, and a lot of companies are trying to market. The days are not that, we will have very soon some devices like Apple devices telling you that your heart rate is high. You should have, get it checked. Like pain triggers, pain levels can be monitored. Biofeedback therapy, again, wearables equipped with biofeedback capabilities can monitor physiological parameters such as heart rate, muscle tension, and etc. With these devices, they will provide feedback to the patients, helping them manage the stress and pain throughout the relaxation techniques. Now, all this data can be analyzed, and again, research into define pain management strategies can be used and to develop various new treatments and intervention. Role of artificial intelligence, yes, there are various models for artificial intelligence. Predictive analytics are one AI algorithms which can actually analyze the patient data and predict pain, flare-ups, and treatment responses, allowing for proactive management. Personalized treatment plans based on the individual's patient profile, optimizing efficacy and minimizing side effects, and diagnostic assistance. Machine learning can be models can be used for diagnosing underlying causes of chronic pain, improving accuracy and speed. Virtual health assistants, AI-driven chatbots, and virtual assistants can provide support and clear the queries of patients, offering real-time advice. Again, real research and development, AI accelerates the drug discovery and help development of new pain management therapies by analyzing vast data sets and identifying potential candidates. This is the article we actually worked on last year for this intervention chronic pain medicine. We all had to, that is for a ready reference. We can use it for our own study. Thank you.
Okay, thank you.
Thank you, sir.
Today. So I think this was an excellent talk. Now we open the forum for some questions. I think I'll just put in the questions which are in the chat box. So this is about from Dr. Rajesh Rao. He's asking about the comments on the paracetamol 1 gram IV versus paracetamol. If we can give 300 mg ampoules into 3 IV. So there is a cost difference. So Dr. Umesh, I think you can take this question and reply.
Yes. So basically, debate was there whether to go for this Perfalgan, and when this patent was made by them for 1 gram paracetamol. But many of the literature has published that the benefits of 1 gram paracetamol over this ampule, because what these ampules do, they are either in the powdered form, and we have to constitute them, and then we can give them IV or in 100 ml NS or in something like that. But the potency is lower when it was found. And one paper I was reading, they showed that 1 gram paracetamol has higher bioavailability. But ultimately, FDA approval is also lost for these 300 milligram ampules. I don't know why. Maybe they might be needing to promote this 1 gram more. But research is going on, and ultimately the 1 gram paracetamol is proving better in that. So cost is definitely the reason, but if FDA is not approving, then we will have to use 1 gram paracetamol for better results.
I think definitely the bioavailability of the 300 milligrams multiplied by 3 is less, and so it gets oxidized also. So the intravenous paracetamol that is available in 100 cc
And
that is specially designed to avoid oxidization.
If that photosensitivity problem is
Yes,
there,
yes,
precipitates, if they are formed, they will cause pain at the site of injection.
yes.
That is also one of the sides.
There was another comment. Umesh, you can take that. Dr. Rajesh wants you to comment on transdermal patches. And even I want to know whether the transdermal patches like buprenorphine patches, how much is the risk of respiratory depression? Suppose you are using 10 micrograms patch, 10 micrograms per hour. So is there any risk of respiratory depression?
No, patches are better as far as respiratory depression is concerned, rather, compared to other routes of administration. But if generally what we use, if we compare with fentanyl and buprenorphine, fentanyl would be better, because then in cancer pain we are using if the patient is already moribund, the cancer patients are generally palliative care, we are using these patches. So these comorbid patients behave better with fentanyl. Buprenorphine may cause respiratory depression in these patients specifically. But otherwise, if we are talking about acute pain, like orthopedic pain or some post-operative analgesia, if we are using these buprenorphine patches, then they don't have any significant respiratory depressive effect. Means we are using rampantly in our institute also, and in private practice also we are using it. So they are not causing that much respiratory depression as such. But when we compare with fentanyl, definitely fentanyl would be better.
Yes, of course, because fentanyl is more potent as compared to buprenorphine and the effect on new receptors. So there is another question for you, Umesh. When multiple modes and drugs are used for post-op analgesia, should the dosage for each to be altered?
Yes, of course, it is a balanced analgesia basically. We have to titrate our doses. We don't want side effects and we don't want supra-additive effects. So if we are using multimodal analgesia, we will have to titrate the dose. And definitely the requirement of other analgesics would be decreased if we are using combination therapy. So it is kind of a rescue analgesia. When we are using it, the other requirement of other drugs will decrease.
So I would just like to add one comment. The use of patches for acute pain is actually not indicated. Actually, if you see, because the duration of onset is very slow, so all these patches will have their transdermal and the onset will be delayed. So they were not intended to be used in the way they are being used rampantly.
They are being used. Even general practitioners prescribe the
Yes, that is
transdermal.
actually a misuse. But
Yes,
then
yes.
what happens is that this pharma industry, they drive the research in such a way. So you will find such papers now coming up for their use in acute pain. Actually, it is very risky. I'll tell you, they are not recommended. If you see the older guideline, like 3 years back, they were not recommended. Now, what is happening is people, especially oncologists, they are prescribing like the bundles of patches people are buying, and they are going to their far off stations, like somebody who's come to say Bombay or Pune or any center, and then this is written, and every day they are applying the patch, and then for third day they are changing, especially fentanyl patch. Now they are being prescribed 25 micrograms, which is quite a safe dose for a 60 kg or 80 kg person. So nothing is happening. So things are going on till nothing bad happens if nobody makes a fuss. But I will point your this thing to the Dr. Umesh's slide. In one slide, he has mentioned opioid epidemic. And on the other side, he in India also, if you see, the consumption of opioids is rising, and we see a very wide trend. So I practice only chronic pain exclusively, and you will be surprised to know that when the patient comes to me from onco background or this oncologist, or so there's not even one patient now who is not on morphine, not on patches, and because they're already given them with the chemo only. So chemo start with the patch, and this is sent. And next time, the patient refills it automatically. So the thing keeps on growing. They need a triplicate prescription, but they are managing that also because of the palliative care program. It is anybody with that short CCEPC course, which is a very short course. is now authorized to write that also. So, so it is a very concerted effort to push these opioids, which are now being driven out of the developed countries into the developing countries, which is India. It is just like, although I mean, this is we are doctors, but we should understand the psychology so that we can, be away from all this thing. Like just like they are being driven out from the developed world, and the consumption market is in India. And you'll be surprised to know that most of them were manufactured in India, any which ways. So earlier it was manufactured in India, used in other countries. Now it is manufactured in India and used in India. So that is the thing which is there. And as far as ma'am respiratory depression is concerned, buprenorphine is got very low potential for respiratory depression. That also it has an advantage that it is a 7-day patch. So for that reason, the 5 mg patch is hugely popular. Like if you write it, it's kind of a placebo also, even if it doesn't affect well. And it's kind
It
of
does have effect. It does have effect because our patients are, opioid naive. Our patients are not exposed to opioids. So the 5 microgram patch also does have good effect.
So the 5 this mg patch, this is actually, if you put it, many people are putting it post-op also, because they think that initially for the 6-7 days only the pain is high. And I've seen a lot of even acute surgeries which are done, like probably a TKR or something. So where the initial time they expect a baseline pain to be there, it is being put regularly now. It
Yes.
is very regular.
Yes.
This is my observation. So I think we check for other questions. Any question to Dr. Samarjit? Please type here. Any comments by any of the senior colleagues? Okay.
There is one question here in chat box. When multiple modes and drugs are used for postoperative analgesia, should the dosage of each be altered?
Vinash, we took that question.
Yeah, this already
Yeah.
been.
Yeah.
Okay, so I think there are no more questions.
Okay, Rajesh, if there is no question, I think we will stop.
So just for the benefit of the house, today the topic was about pain. So I have put in some TED Talks here. Guys, please, when you get time, please go through them. They are very exciting. And it totally, even as anesthesiologist, it's like quite interesting to go through these. And I mean, I think they will change your perspective towards pain. So just go through them.
Okay, thank you. Thank you, sir. I'm very happy with today's webinar. First of all, I'm on behalf of SAMS very much thankful to Dr. Samarjit Dey, sir, for accepting our request for today's webinar. I'm also thankful to Dr. Umesh Ramtani, sir, for accepting our invitation for today's webinar. And I'm very much thankful to Dr. Siddharth Verma, sir. He's a pain specialist from Navi Mumbai, and he can spare the time for our webinar from his very busy schedule. I congratulate to Dr. Parna Thakkar ma'am for the release of second issue. Really, we are very much pleased with the SAMS newsletter release. I'm also thankful to all the office bearers of SAMS and the viewers attendance of today's webinar. Thank you so much.
Thank you. Thank you very much, sir.
Thank you.
Thank you. Thank you very much, everyone.
Thank you.
Bye.
Bye. Thank you.
Thank you.
सर मीटिंग एंड करूँ का?
हाँ कर